We have Kelsey coming back. It's surprisingly been 3 years. I thought I was asking her way too soon. Hey, nagging her again to come back, but it's been 3 years, so that's a good amount of time to formulate some extra questions for her. And she's got a new business and kind of runs the show for a decent amount of it, so she's going to be sharing that with us. But she knows the grind and she understands the game of type 1 diabetes a little bit more. So sometimes we just feel a little bit more comfortable with someone that kind of understands or has a stake in the game. And so I'll turn it over to Kelsey here. Thank you for coming once again.
Yeah, thank you for having me. I have a little information for us about eye health in general and as it correlates to being diabetics. And so, if you guys have questions along the way, don't hesitate to ask, but I'll go through a few things and just let me know if anyone has anything on their mind. So, I have been diabetic since 1999. So went through all the iterations of different ways to treat it along the way as well. Um, I ended up getting interested in optometry because I was always so intrigued how our overall health can impact our vision and being diabetic, how important it was to get our eyes checked to make sure that we're keeping our best vision for as long as possible. So my optometrist got me interested in it at an early age. I ended up going to Madison for undergrad and then out to Pennsylvania College of Optometry in Philly for optometry school. Um, Worked a few places along the way, ended up specializing more in functional care, but like how people's eyes work together, whether it be from like kiddos that have like a lazy eye or an eye turn, or we don't have as good of vision in one eye, have poor depth perception, maybe have had an injury, like a concussion, or a traumatic brain injury, acquired brain injury like strokes, cranial nerve palsies, and kind of working with people on the functionality of their vision. So my partner and I opened up a new joint clinic in Richfield. We're at Swoop Eye Care. We do all sorts of primary care, of course, diabetic eye exams, treating glaucoma, macular degeneration, things like that. And then I opened up the Vision Therapy Center right next door. So we're two businesses in one building now, and hoping to service a lot of people. Not a lot of optometrists, private optometrists in that area. And so we're kind of right off of 62 and 35W there. Okay. So, as I was saying, the importance of getting your annual eye exam, it's the only place in our body that we can see those live blood vessels. And so, if we're getting changes, whether it be to our prescription or the blood vessels and the central vision of our eye, we can see that happening when we go through like a dilated eye exam. We have special imaging and technology to, see the extent of it. But if it's happening in our eyes, it's likely happening to the other blood vessels throughout our body. But this is the only place where you can really see it. And so different areas that can be affected that we look closely at with your diabetic eye exam. We can especially get changes to our iris, the lens of our eye, the retina, the optic nerve, and that macular areas are a very central vision, that 20/20 vision area. So some of the complications that we can be, more susceptible to getting as diabetics, certainly the diabetic retinopathy in the back of our eye. We can get diabetic cataracts in that natural lens of our eye. We can get glaucoma, which is a disease that affects the optic nerve, which involves our peripheral vision. We can have troubles with the vasculature of our eyes, whether it be the vein or arteries having occlusions or hemorrhaging, and ocular surface disease such as dry eye. So some of the risk factors for getting ocular complications from our diabetes is, of course, our overall A1C control, keeping that under a 7 for the most part can help to reduce some of these complications. As we have the newer technologies, though, our time and range is also important when it comes to our CGMs. If we in general have a good A1C, but we have a lot of yin and yang throughout the days and months, we certainly can see some damage to our vasculature still. The amount of time, the duration that we've been diabetic can be a risk factor in general. So not necessarily that you have to have a time of poor control or an elevated A1C or poor time in range, but as the years go on, we're just more likely to be susceptible to some of the complications with time. And then any other co-diseases such as having high blood pressure, high cholesterol, anemia, troubles with our kidneys, and the trauma of pregnancy can certainly change our ocular health. So I thought I'd go through a couple of those a little bit more in depth. So diabetic retinopathy is a major reason for new blindness in adults in the United States from ages 20 to 74. So certainly a good part of the population there. The ways that it can manifest can be blurred vision, spots in your vision, hazy vision, and if early, you can have no symptoms at all, which is also why it's important that we look in and take a peek and let you know as soon as we see things. The sooner that we see things and can manage or treat, the better the outcomes for us visually. Different severities of diabetic retinopathy that we may have heard of along the way. Mild, moderate, severe, proliferative when we're growing new blood vessels or having fluid in our eye, like macular edema. The kind of some of the statistics that come along with being diabetic for greater than 10 years, about 74% of diabetics have some sort of diabetic retinopathy, even if it's mild. And over 20 years of being diabetic, there's about 95% of people of diabetics that can have the diabetic retinopathy. It can come and go, though. It can get better. The goal is to, stay the same or improve it, of course. Our best treatment is our overall control of our diabetes and blood sugars. But there are certain cases that require laser, ocular injections, various type of injections depending on what we're having going on. But having a 10% reduction in our A1C can be associated with having 45% improvement in the diabetic retinopathy or the changes in the back of our eye. So here's just a little example of a normal retina and so an extreme case of, severe diabetic retinopathy and some of the things that we're looking for. And so I always recommend a dilated eye exam, but it's also very helpful if the office has the technology of doing like a retinal scan that might be called like an optomap image, because then we can do a side-by-side. So if we see any small changes of the blood vessels over the years, we can see it at a very small scale year to year. So being diabetic, we're more susceptible to getting cataracts that can come earlier in life. The average age for cataract surgery is about 71. Sometimes diabetics can have cataracts as early as 20 years prior to that. And we're 2 to 5 times more likely to have that earlier age cataract formation. Not everyone that gets an early cataract is diabetic, but there's certainly a chance that we get them earlier in life than maybe some of our peers. Some of our symptoms we might experience would be halos, especially with headlights, driving down the road, hazy vision in general, like a fogginess to it, needing more light when we're doing things like reading, and then just in general, our best corrected visual acuity being reduced. So instead of being 20/20, we might be 20/30, 20/50. 20/50 is that limit to be able to drive legally in Minnesota. And so there's different types of cataracts that we can get. A snowflake is a special cataract that's a signature of diabetics. But in general, we can get a more focal cataract on the back of our lens called a posterior subcapsular cataract, or cortical ones where they're kind of like little spikes. So only parts of our vision are affected. And the good news is very treatable. The surgeons can remove that natural lens and replace it with a new clear lens. And so a lot of patients see much better after cataract surgery. That healing process for diabetics can be a little extended, that we're on eye drops and need to watch that macular area very closely for edema. But in general, very treatable. Glaucoma, we also can have about a 35% increased risk of compared to our peers. Um, Glaucoma is a disease that affects our optic nerve, and it can cause us to have damage to our peripheral vision. So if we are looking out into the world, this is our right eye. Can you guys see my mouse okay?
Mhm.
And if you start to have damage from glaucoma, we start to get, the edges, of our peripheral vision affected at first. But if we see changes to your optic nerve, we can typically detect it before you have visual field loss. And so that's always the goal. We don't want to end up with our tunnel vision here where we're only having 5 or 10 degrees of our central vision left over. Also very treatable, especially when found in the early stages. Besides being diabetic, if it's, as the years go on, we become more susceptible to both glaucoma and cataracts in general. Or if we have a family history, the pressure in your eye, when it's increased, puts pressure on the nerve that then causes the peripheral vision loss. But it can be very easily treated with either eye drops that you take once a day or twice a day, or certain very particular types of laser that help with the drainage in our eye, or a surgery that you can put like a little tube in to help with the drainage as well, or like a little shunt. So there's multiple options when it comes to glaucoma, depending on the type and the severity. But once again, the early detection is key. So getting in once a year, getting the nerve checked and those eye pressures checked is very important. Vein and artery occlusions, so either having loss of blood flow to the eye or having blood outside of those blood vessels can cause damage to our vision. Some of that with this type of occurrence, you would have like a sudden change to your vision, and sometimes that vision doesn't recover from, especially the artery occlusions. In general, the treatment for them is just the overall health control. Being diabetic is one risk factor, of course, but if we also have uncontrolled blood pressure, high lipids, can contribute to having troubles with our occlusion of our veins as well. On the surface of our eye, we can get irritation, dry eye disease. We can be more prone to some of that chronic inflammation. And so our tears can evaporate more quickly because our nerves, having damaged them sometimes, don't then release enough tears, or we don't get the stimulant to then blink enough. And so we can have changes to our vision every time we're blinking, have to do like excessive or frequent blinking to keep our vision clear. Redness of our eyes, or almost feel like something's in our eye from dry eye, like sandy feeling, like a gritty feeling, like there's an eyelash in our eye, even though there's not. Lots of different dry eye treatments, ranging from simple things like eye drops and using artificial tears. There's eye drops that have medication in them to help us produce more tears and calm down inflammation. The glands in our eyelids, every time we blink, also secrete oils. And so we can treat the glands of the eyelids to help produce more oils. And then if those oils are secreted and help to keep our own tears on our eye, it can help with our natural tear film. Omega-3s can also help support, especially our oil glands or our meibomian gland function. And there's some specialty treatments in the office for, some more severe dry eye, like Lipoflow, that helps with the glands, or IPL that can help with inflammation. And sometimes people really struggle with traditional contact lenses when we're having dry eye. There's certainly a lot of specialty lenses when it comes to like daily contact lenses, or even scleral lenses, where it helps to have a little bit more of a tear film in between the lens and our eye. Certainly can improve vision and comfort with some of that specialty lens work. In general, when we're having swings to our blood sugars, we can see swings to our prescription. I've even seen it in myself, going from, say, like an A1C of 7 to like an A1C of 6. I was less nearsighted, so you can get a shift in your prescription just from your A1C shifting, whether it's a 14 to a 10 or a 6 to a 5. You can still have changes to your vision. So if we see you and you've had a big change from the previous visit, sometimes and it's also that you've recently had a blood draw and you know that your A1C has recently changed a bit, I might recommend, hey, if we wait 3 months and you keep maintaining these same blood sugar levels, let's make sure this is where it's going to end up versus shifting another click or two by the next time I see you. We want to make sure that, you know, you're getting your money's worth out of your glasses and not having to change your prescription every month or two if those numbers are changing. Of course, we want you to have your best vision, so I'm not going to hold the prescription back from you. But in general, if we do see big changes, you know, we'll let you know that the 3-month rule is kind of a good rule of thumb in terms of lens replacement. So that can happen from fluid retention in the lens of our eye, losing fluid in our lens as our blood sugars change, or in those retinal layers in the back of our eye, having that fluid buildup and shifting our prescription. Macular degeneration is another one that a lot of people ask about. It's not as highly correlated with being diabetic. In general, it's a little bit more associated with type 2 diabetics, more so because it's also associated with people later in life as the age increases. And so the family history, your age, and if you are a smoker are the biggest risk factors for developing macular degeneration. Certainly different demographics are more likely to have it as well. Being Caucasian, I'm more likely to have it than a Hispanic or an African American. And so with macular degeneration, that central vision area being the macula, we tend to lose some of our sharp, 20/20 vision, that central vision area. And so, we can still see the periphery of the greenery, but maybe lose some of the central imagery of her face. Best way to prevent macular degeneration is not smoking, wearing sunglasses when you're outside. And if we see early signs of it, we may have you supplement with vitamins that have lutein and zeaxanthin in it. Most of them are formulated called the AREDS 2 formula. If you are not having macular degeneration, there's not necessarily a benefit to taking lutein and zeaxanthin. It comes naturally in our diet if you're getting leafy greens, colorful fruits and vegetables. It's not necessarily been shown to be beneficial to start taking AREDS if you don't have any early signs of it. So a couple reminders just, of ways that we can lower our risks of having ocular complications. Like we said, the A1C, time and range, controlling other factors of our overall health, like blood pressure and cholesterol, which you don't know unless you look for it. And so actually going to your visits with endocrinology and primary care to have the blood work done. There's certainly been many a times when I question a patient, if they have anything else going on, and they also haven't been to the regular doctor in 3 years, so it's hard to say. The diabetic eye exam we'll recommend once a year unless we see retinopathy or things are changing, then we may have you come every 3 to 6 months. Not smoking, regular exercise, hydration, and your balanced diet will have the vitamins that are healthy for your eyes. You don't need to go out and buy a magic pill that they're telling you is going to save your vision. If you aren't having, someone that's eating leafy greens and, colorful fruits and vegetables and a diet rich in omega-3s, you can think about supplementing with certainly like a multivitamin or omega-3 supplements. But you do naturally get enough in your diet if you're having a well-rounded diet. And then just a little plug about what is vision therapy. I think, some people sometimes aren't sure what I actually do for some of that functional care. So as I mentioned, kids are having a family history of like a lazy eye or an eye turn and traumatic or acquired brain injuries can present to us as seeing double, closing an eye when they're reading, repeating lines, skipping lines when they're reading, doing poorly as like kiddos switch from like learning to read and then having to read to learn, and then they might lag behind their peers, getting headaches anytime we're reading or doing screen time, having poor hand-eye coordination or depth perception. So those all can be treated with different types of specialty lenses, such as prism, occluders, filters, tints. And then vision therapy, you come in once a week to the office and have a one-on-one session, almost like a PT or an OT. But we specialize in how the brain processes your visual pathways. And we send you home with exercises, and it's a little program. Takes about probably 16 to 20 weeks on average, depending on what the diagnoses are. But certainly a great way to help boost how people are feeling and seeing. So that's just kind of a little overview that I had for you guys tonight. Do you guys have any questions in particular about ocular health or diabetics and ocular health?
So there was two like businesses, I guess, if you will. One of them was the Swoop, was it?
Yep. So Swoop Eye Care is more the side where we do primary care eye exams, diabetic eye exams,
Okay.
treat glaucoma, macular degeneration, things like that. And then, and we're in one building. So my partner owns primary care, and then I own the therapy. So I really only see patients on my side just for the sessions, but we do all the evals and everything through Swoop Eye Care.
Okay.
We take all major medical insurances. He's done a really great job, Dr. Walrick, of getting us on just about every panel you could think about. There's, of course, a couple oddballs, but sometimes even when we have to refer a patient to an ophthalmologist, we get a bounce back that they're not in network. We're more in network for the insurance companies than some of the OMDs. So anyways, yeah, so any sort of like, regular eye exam or diabetic eye exam would be through Swoop Eye Care.
Okay.
And then just the therapy sessions I do at New Vision.
Okay. So are you taking new patients?
Of course, yeah, always
Okay.
taking new
All right.
patients. We've hopefully made it really easy. swoopeye.com, you can do online booking. Once you get a text message from us too of like your appointment reminder, you can text us back questions or your insurance card pictures and things like that to prep for your appointment. We send you all the paperwork ahead of time. And then we always send Brad a note or whoever your endocrinologist is, letting them know how your visit went too.
Okay. All right.
Yeah.
Thank you.
Yeah, of course.
Up to 87%.
I have a question.
A little joy you
Go ahead.
Yeah.
What is standard eye pressure? What would be considered normal for glaucoma?
Without knowing anything else, 8 to 21 is typically like the normal range. If you're outside that range, we start to watch you more closely. And then depending on multiple factors, usually around 25, I get a little bit more like we need to maybe treat you, depending on how your scans go. We'll do like OCTs and visual fields before we make a decision. The more information we have and the more like serial scans that we have, the easier it is to make a treatment decision and what treatment would be best for you. But yeah, usually about 8 to 21 is where the normal cutoff is.
Thank you. I noticed that
someone,
Reed has a question, and I agree with his question. I'm LADA also, and a lot of the things you're talking about, I have not experienced yet. And I've been LADA since the year 2000. So
okay, that's very good. And you've been getting your eye exams?
Yeah, every year. Eye exam every year in January. That's the first thing that goes on. And so far I've had no issues other than I mentioned earlier, I had cataract surgery and my eye pressure, they put me on steroids for my eyes due to the previous viral infections I had.
Yes.
And that has increased my eye pressure so that they also put me on a blue cap that helps reduce the eye pressure. And right now it's holding at about 21. So I'm very glad to hear that that is at the high end of normal.
Yep. And a lot of times you can get a spike to your pressure after having gone through cataract surgery in the short term. And so it might not be something that you need long term. But yes, the percentages that I'm spitting out too, that you're maybe part of the 5% with, being 20 years of being diabetic and no retinopathy, which is awesome. We certainly love to see those patients. I love to have a boring note back to the endocrinologist that nothing is wrong. And, technically we do mark it if there's like one pinpoint spot of a dot blot hemorrhage in the back of the eye. And so that is included in the, say the 95% of diabetics over 20 years.
Now, would this be due to the fact that I am LADA and not
It could be. I don't have as many stats specifically on LADA as I do, type 1 versus type 2. But in general, type 2s tend to see more complications earlier just because they've probably had things brewing for longer, where type 1s, we usually get diagnosed a little sooner from the onset of changes. And so typically for type 1s, we might not see things at least, especially for like 5 years, but like a type 2, we could see these, some of these more severe things happen in their first year of being diagnosed just because they probably were diabetic for longer.
Thank you.
Yeah. I see a couple. Sorry, I didn't see some of these questions coming through earlier. I can address a few of these as well. We don't take insurance for the vision therapy side of things. We do accept HSA, FSA, and then we provide a super bill, your coding and your diagnoses, and to help submit for out-of-network coverage. I used to work at a clinic, and we took insurance for vision therapy for 30 years, say. And 3 years ago at the national level, there was a coding change of the codes that we're allowed to use and the verbiage on them. And so if a vision therapist is seeing you, they can't technically bill a certain code now unless the doctor is sitting in on all the sessions. Anyways, it's a policy legislation thing that now we can no longer accept insurance directly. And so nationwide, most vision therapy clinics have moved to out of network because of that. Hoping to go the other direction again, but for right now, it's just the pain that we're dealing with. And then a question about T1D and TBIs. So it depends. Yeah. For, do you recommend eye therapy for a certain amount of time? And it depends on the severity and the diagnoses. So, if I'm watching a patient to make sure that they can converge their eyes and do things up close for a sustained amount of time, you might have the diagnosis of convergence insufficiency if you can't do that. There can be someone that gets double vision and can't do that at 2 feet. And there can be, convergence insufficient patients that can't do that at 8 inches, which, most of our world is hopefully further than 8 inches from our face. And so it does depend on the severity and kind of the whole picture of what's going on to determine how many weeks that you need. And then I take into consideration your goals. Some patients want to get back into playing college sports, and some patients just want to be able to work and drive themselves around town without having to have a chauffeur. And so I take that into consideration as well. And then I had a question about Medica. We are in network for most Medica plans. I don't think I've seen many that we're not in network for with Swoop Eye Care. And then I think I'm caught up on the questions now. Yeah, go ahead, Carol.
My son got diabetes in 1974 when he was 20 months old.
Oh.
And then I unexpectedly developed it in 2001 at the age of 58. And so one of the things that's always been a puzzle is why some people with terrible control do not develop complications, and others with really good control do develop complications. Is that still something that you've heard about?
It certainly is. Some people just have that higher tolerance for extremes in their body. Some people, like say when your blood sugar is low and, someone's 60 versus someone is 30 and they have the same symptoms, or someone doesn't experience symptoms the same way at the same levels. Same thing with severity of complications. Some people just tend to have a little higher resistance to certain types of complications. And it's not always about your control. A lot of times it is about your duration, but, being a newer diabetic, you certainly still could have complications. And it's, what are the other diseases or conditions that we have can certainly influence that. Like I was talking about with just, being diagnosed with hypertension and cholesterol issues and things like that, even if they're under control, the more kind of metabolic diseases that we have, it can be harder for our body. But, certain people certainly have had bad control and haven't had the repercussions of it in terms of other complications. And there is a little mystery to that still, I will say. And maybe
then you
Brad has a better
mentioned,
answer for that.
yeah,
But
you mentioned about the A1C and the time in range and the fluctuation. So what if
yeah.
somebody has a 6.1 A1C
Mm-hmm.
and like 70% time in range, but time in close range, 40 to, what's the other one I'm trying to think of? High of 140 and low of 75. So time in
Yeah.
range in that close range rather than
Yeah.
the
The
normal
type.
ADA version.
Yeah.
But still, even with a good, relatively good time in range and a relatively good A1C, but lots of variations, lots of lows and lots of highs, it still averages out to something sort of good. How risky is that? The very constant variations.
Yeah, it's a similar risk of just having an elevated A1C I've seen. So, having an A1C of, 6.2, but having a lot of high highs and low lows can certainly cause the same damage of just being, say a point higher, like a 7.2 instead of being a 6.2. So the more steady we can see those CGM numbers, also that risk goes down.
Okay.
So I would say I went maybe not quite as equal risk factors, but I would say there's certainly a lot closer than I used to think. We used to only have 4, maybe 6 data points when we were testing our blood sugars with a meter. When I was young, anyways. I was 10 years old, and pricking your fingers 4 to 8 times seemed like excessive amount in my mind. And so I didn't really know, okay, I tested up before a meal and things were fine. I don't know what was happening for those 2 hours in between. Was I going up to 200 and then coming back down, or was I staying at like 100 the whole time? And so that yin yang can be really hard on our vasculature health as well.
How do you feel about the whole new movement to extremely low carb, high fat diets so that you don't have
Yeah,
high blood sugar?
it works for some people. I would say I'm not one of those people because if you go, off of that, it's a lot harder for your body. Like say some people trying the keto diet, certainly some people do well with it, especially I think maybe type 2s maybe a little bit better time than type 1s from what I've heard and seen.
Why would that be?
Just our more immediate effect if we then have a carb. And so if our body adapts to doing low carb, and then we have, say a bun or something that we're not used to having, I've found that if I've gone real low carb and then introduced any sort of carb, it's a lot harder. And I found it's harder for me. And I've heard it from a couple other type 1 diabetics that it's good for maybe 2-3 months. And then our body takes more insulin, even for a lesser amount of carbs.
Okay.
And so that's been my experience with it. I think some people do thrive off of it. I'm not someone that eats the same thing every day, and I do enjoy carbs. And so if you, go off diet for a day or a weekend, it's really hard in terms of, I find managing my insulin levels to control it.
Thank you.
Yeah. Yeah, the sun protection, UVA, UVB protection is very important for our eyes. I think I also get the question a lot of UVA, UVB protection and versus polarized. Polarized definitely offers a lot of comfort to our eyes. Certainly helps a lot with glare coming off of, for us Minnesotans, water and snow. But in general, at least having some sort of sun protection on is very helpful, especially for all of us fair pigmented folks, which looks like most of us in the room here. Because our eyes let in more light and our skin lets, we absorb pigment a little bit differently. And so it certainly can build up in our lens of our eye and in the macular area with macular degeneration and cataracts a little bit quicker than someone who's heavily pigmented.
The one question before that is talking about night shift. I don't know if you have
Oh
anything.
yeah, let's see. You work the night shift. I think the hardest part about the evenings for our eyes is just a lot less light that we're exposed to with everyone trying to, have dimmer settings and driving at night. It's not bad for our eyes, but the wise tale of reading with the light off and it being hard on your eyes, it does cause your accommodative system to work a lot harder because there's less points of reference as where your eyes are supposed to focus. And so it certainly can be very tiring on our accommodative system. In terms of damage to your eyes, I don't know any strong correlations of, working night shift. I would say it's more of a comfort thing of your eyes with mostly with the exposure to how much light we're getting.
I have a question. The UVA and UVB protection. I heard rumor many years ago that, and I just want to verify, see if you know anything about this. The plastic lenses that originally came out with UV protection, I was told that they only are good for a couple of years before the protection kind of wears off, whereas the glass ones are good for as long as you wear them. Now,
Yes.
have you heard anything similar,
that
close?
does sound familiar with, I would say a little before my day of some of the lenses being made out of different materials. Nowadays, I think the coatings tend to wear off and disrupt people's vision before the UV protection would wear off. And certainly the different types of transitions can certainly wear over time where that it's not protecting you as much. I think their lifespan has increased over the years, but the transitions especially still wear off over time. Glass, it certainly can hold the prescriptions and some of the tints and things better. But it's also, we don't do much glass anymore. So that was also something that I'm not as exposed to anymore. We use a lot of Trivex, polycarbonate, and high index now.
Okay, I was just curious.
And a lot of times you'll be able to tell with the transitions too, those lenses that get dark when you go outside, because they will stop getting as dark as they used to be. So then that protection is going down as well.
I also heard that you could check your UV protection with an ultraviolet light
Yeah, we have one in the office.
On like a dollar bill or something?
Yeah, we have ways you can check out the UV protection with the laser in the office. And we can make sure a transition changes the full amount. And that it's, for us too, we also check the color, that is the right color that you chose and things like that of other fun stuff. But yeah, certainly there's some fun ways to check that out.
And is there a fee for that in your office?
No, typically no. You just anytime that we're open, you can come in and talk to the opticians. They're on staff anytime that we're open. Ask any questions about different lens features and coatings and transitions or polarization. Yeah, I'm more than happy to help you with that.
Cool. Thank you.
Yeah. And a fun fact about transitions, it actually offers the most amount of blue light protection too for people who are on the computer all day. And so it can help with the comfort of our eyes inside and outside.
So I just shared some links.
Oh, thanks, Brad. Yeah.
There's the Swoop Eye Care and then the New Vision, because you're at two different places, or they're kind of one. How's
So
it
it's
work?
the same building, two different clinics. And on Swoop Eye Care, it's very well laid out, how to make an appointment, but also like checking your insurance and stuff. And then our staff is happy to, help you look up if you're in network and stuff. If you give us a call, the phone number is listed on both websites too. You can also text. And so it's kind of nice if you don't want to leave us a voicemail, or if you just want to shoot us a message that's, non-urgent, we'll get back to you within the day, of course. You can certainly just shoot us a message that way too, and we're happy to help out. Or send us a picture of your insurance card. We can help you look to make sure are you in network and things like that. Yeah, question about sounds like on the white part of your eye having some small blood vessels that were broken. And is that a type of retinopathy or from rubbing your eyes? Certainly on the white part of our eye, I'm less worried about retinopathy, especially if we are someone that maybe accidentally rubbed our eye or bumped it, kind of had an incident there. We certainly can see those blood vessels break, and it's more like a bruise. And so it looks a lot worse because our conjunctiva is made up of two layers. So the white part, we have some blood vessels, and then the clear part. So if one of those blood vessels breaks in between, that blood just gets smushed and it looks really red. And it certainly can look worse before it gets better. And then it'll also go through those weird color stages of being like yellowing and things like that. And so I am much less concerned about that. The retinopathy of the blood vessels in the back of your eye is where we typically see those changes around the iris, the colored part of your eye, which is not exposed to the exterior world. You won't be able to rub your iris or retina. In general, for dry eyes and seasonal allergies, Pataday is my favorite allergy eye drop. It has the mast cell stabilizer and the antihistamine, so it helps to stop the itch and prevent it. So it's kind of like a Zyrtec or a Claritin for our eye. You can take it. I know it's going to be my bad week of allergies. Just take it for the week straight. It's completely safe to use it like that. Or, I'm having one bad day. Okay, I throw a drop in of that Pataday. And so that's a great option for allergies. Dry eyes, I really like Refresh, Sustain, Blink. Those are all good brands. And depending on the person, if they need that oil component, they all have different versions. So they're traditional tiers, fine for most people. Refresh has one called Omegas. Sustain is called Complete. They have a little bit more of that oil component, so it stays on your eye a little bit longer. Typically, you can't use when contact lenses are in, but they tend to, help out a little bit more for people who have dry eye and wear glasses. And I can type a few of those in there too. A lot of times, though, too, those meibomian glands are affected, those oil glands I was talking about. So I also, when we have dry eye, I always recommend hot compress to get those oils flowing a little better. Pataday also comes in different strengths. I would get the regular extra strength. You just get a little more bang for your buck. You only have to take it one time a day instead of twice a day.
Kelsey, I kind of asked you this before. I've had a few patients that were kind of slipping by 5, 6 years without their eye exam, and they're like, "Oh, my eyes are doing just fine," whatever. How severe does it have to get until you're kind of realizing, hey, my vision's changed because of retinopathy? Does it have to be pretty far
Yeah.
into it, not just mild, but moderate or proliferative? And if you get treatment a little bit sooner, I mean, how many more years of vision can you have theoretically?
Yeah. So the earlier that we find retinopathy and can treat it, if it needs to be treated, or control the factors that we can, like our blood sugar and time and range and things like that, much better outcomes. 50 to 75% of retinopathy patients with injections for edema can get better. And I think it was like around 53% can get significantly better, which I think they had marked as 10 letters or better. So essentially 2.5 lines of vision or better. And so it's very important that the earlier we see it, we can do something about it. So even if you're not having changes to your vision, once a year still going in to make sure everything is, status quo. Because you can have moderate diabetic retinopathy and not have symptoms if it's sparing that, very central 5 degrees of your macula. I had someone come in too, and, most of the time it's a bilateral condition, but it can be asymmetric. So I had someone come in a couple weeks ago and they didn't realize how blurry they were in one eye because they're walking around with both eyes open like we do all day, every day. And they ended up having a vein occlusion and they just thought they had a little blurry vision, but then they cover their eye and they're only like 2100. But, it's not everyone's first thought to cover an eye when they are thinking about checking their vision. And so that's very important too, even a little self-test at home, checking each eye individually. Because the sooner the better in terms of treating and long-term outcomes. Sometimes that central vision, if the edema has been there a while, it's a little harder to treat and it's a little harder to get your vision back. But the neovascularization, where you're getting that new blood vessel growth because your eye is not getting enough blood flow and oxygen, it can show up in places that you don't also have symptoms. And so getting laser treatment for that or the anti-VEGF injections before it starts to affect your vision is very important too.
We have some more questions in there, but one other question is, what patients are not a good fit for you? Because you're not doing eye injections, right? I think maybe instead of them being like, hey, I thought you'd be great to see. I'd love to see you, but hey, Kelsey doesn't do this or something.
Yeah. So we don't do the injections. We don't do cataract surgery, but we co-manage all of them. And so certainly if you're someone that, the surgeon recommends cataract surgery, the 1 day post-op we do at our office. We can, if you like, and any of the eye drop management we do. So, okay, I'm seeing a little more inflammation after cataract surgery. I can adjust those medications myself. I can prescribe more bottles if we need an extension of them. With the injections, typically this retinal surgeons will see you. Most common around here is RCM in Edina area, and they'll see you for their injections, but they actually don't like to check glasses and contacts and the dry eye stuff and like anything besides the injection. And so it's still important to get your, prescription checked once a year, make sure you have the best vision, or things are finally plateauing and improving with injections. Now we need to recheck your prescription for your glasses, happy to do that sort of thing as well. Let's see here.
Elizabeth Blatchley had the most good question.
Okay, so for macular degeneration, so having a direct parent that has macular degeneration, we are more susceptible to developing it. It doesn't mean we have to. The beginning signs of it that I see under the microscope are these little drusen deposits near your central vision. That's when I would start to recommend the AREDS formula for vitamin supplementation. I always recommend no smoking, light exercise, or regular routine exercise, which are the smoking and the is the biggest factor for macular degeneration, and then our family history is probably second there. The progression of macular degeneration, first we treat with supplements and close monitoring, is when you start to get the fluid with macular degeneration, and that's when you need the injections. Your vision usually is about like 20/50, I would say, before that starts to happen. Of course, there's a couple of people outside the bell curve on that one. And so, yep, I think just in general, the best thing is the overall health. Again, with diabetes management, blood pressure, cholesterol, not smoking, and your overall, exercise and diet there. So preventing further disease progression past being diagnosed.
Thank you. That's
Yeah. So did that answer it well enough for you there?
Yeah. Yep.
Okay.
I get annual exams too.
Yeah.
Exams, so staying on top
So,
of it.
yep. Staying on top of it is the
Get
best
my
thing you can do.
A1C down. So.
Yep. And like I said, being diabetic is not as big of a risk factor for macular degeneration as the other things, but it's a small correlation.
Sure. Okay. Thank you.
Oh, cataract surgery now has sun protection built into them. That is, yeah, I think that, I haven't, I'm trying to think of what the routine ones did. I wonder if that's a specialty lens now that they're doing. Where did you have cataract surgery at?
I had it done in Hutchinson at Regional Eye
Okay.
Center, and I did have to get lenses for astigmatism in both my eyes.
Yep.
So,
those toric lenses. Yep.
Yeah. So I had to pay extra, but he said all the new lenses had UV protection in them, and I wasn't familiar with that, so I didn't.
I will have to double check with our surgeons. I'm not as familiar about them advertising about the sun protection with that, so I will double check with them. I feel like that is quite a new thing there.
Okay. And I did also have more blood sugar swings, I think, with the prednisone eye drops.
Yeah.
My last month, or the month of April, was not good. So anyway, but I was only like 60% in range. Now I'm at 80 to 90%.
Yeah,
with all my drops. So
with it being that a small, I don't want to say trauma to the body, but having surgery and then going with the prednisolone certainly can affect the blood sugar a little bit. It's typically not as much as the oral, but certainly it still can affect our control there. I also see a question about diabetes and Sjogren's. That combo with the inflammation that you typically get with also with Sjogren's, I usually go for one of the medicated drops, Restasis, Xiidra, Cequa. Those are all really good options. It's one that you have to take twice a day, every day, to notice the benefits from it of the inflammation calming and the production of more tears. Some people, you have to wait about 1 to 2 months to feel those effects of improvement too. But I typically would go that route for people with Sjogren's versus the over-the-counters are fine, certainly better than nothing. But I would say those types of patients tend to do really well on those types of medicated drops. And then looks like we have a question about light therapy. I don't know as much about that light therapy. Is that for treatment with, in reference to macular degeneration?
It is. Sorry, I'm stealing your time from diabetic-related stuff. I saw my mother-in-law yesterday, and I'm like, well, I've got an expert here. I might as well pose the question. So,
yeah, I unfortunately do not know as much about that. It's typically doing a lot more with co-managing with surgeons that do the injections. I think there are people that, are recommending it now. I just don't know as much about it to feel like I can advise on it.
Just one hopefully short question. How common is it to change from wet MD to dry MD?
So to get the wet under control and go back to dry, you mean?
Well, again, sorry, this is my mother-in-law, but she had wet MD. She was getting all of the shots in her eyes. And now her new ophthalmologist or eye specialist has told her that it's changed to dry MD.
So if that fluid is under control, there's no neovascular net into that central vision area, you can be considered dry again. I think you'll always have the stamp on your chart that you were wet at one time and that you're, a higher probability of going back wet. And so with injections, getting that fluid under control, they probably did like an OCT and saw that there's no no longer, any sort of neovascular net there. And so, yeah, it can happen. I would say it usually takes years of injections, 1 to 4 years of injections, I would say, just from personal experience. That's not a study stat there, but it certainly can happen.
Thank you.
Yeah. And, they usually do those injections kind of tighter together, and then they spread them out, and then maybe you don't need some for, 6 months or a year. And then you just keep watching closely to make sure you don't need to restart them. The time. So yes, thoughts on MDs versus ODs checking for diabetic eye health. I was also told that when I was very young, that I should be seeing an MD at least every other year, and I did for a couple years. But the knowledge that the optometrists now have of the systemic, body of the whole body, and the technology that we have to be able to assess it, we're certainly capable of letting the type of retinopathy or conditions that you may have associated with type 1 or diabetes in general. The only time that I co-manage with MDs really is to let them know that, oh yeah, it's time for he or she likely needs an injection, or likely needs treatment because things are so severe, or severe enough. And so it's kind of like the gatekeeper of your primary care doctor, and then seeing like a rheumatologist or someone that, can't do the things that we can do. And so that baseline level, and managing mild diabetic retinopathy, things that don't need treatment, we are very capable of now. Certain clinics certainly have different tests though. So you definitely want to go somewhere that has the imaging technologies, which we have all that at Swoop Eye Care with OCTs, OptoMaps, and visual fields. And not every clinic has that, I guess I'll say as a caveat. Yeah, very welcome. I'm glad to see so many people in tonight. Any other questions or thoughts? Comments on personal eye experience?
Kelsey, there's no really studies that you've seen that like lows can cause any eye issue, right?
Right. No, being like too low, or of like just in general, or like too low
Blood
of an
sugars,
A1C.
yeah.
Yeah. No, not as much. I feel like I was posed a question at one point about that as well, and it's nothing that they're hammering to us with, continuing education or anything like that I've heard of that's new about it either. I'll certainly keep my ear out for it and let you know if I do hear something.
It's a hard thing to study and make people do
Yeah,
years of time and
exactly.
be like, is it this, that? So
Yeah.
I just was curious because I get people that ask that, and I'm like, no, besides, passing
Yep.
out and having.
Yeah, I think other things come along before the changes to the eye, if I had to guess.
Yeah. If life is more important than
Yeah. I think there's
sense.
probably some more immediate dangers versus long-term changes to the eye.
Can I ask a question, Kelsey?
Yeah.
You've great information that you've given. I've been a type 1 for 50 plus years, 58 years exactly, but I'm dealing with detached retina,
Okay.
and both my endo and my retina specialist slash surgeon does not think that my diabetes is the cause of it. Just hearing all the issues with eye diseases that you've talked about, nothing was mentioned about detached retina. I was always seeing an optometrist who referred me to a diabetic retinopathy doctor who I was seeing twice a year. And then she moved me to just once a year because my eyes were looking so good. And then I had cataract surgery. And so my feeling is that this cataract surgery could have been could be the
I would
cause
say
of.
that was the higher probability of being a contributing factor is the cataract surgery. The biggest risk factors for retinal detachments in general are high myopes or high negative prescription nearsighted people. And if you were to have proliferative diabetic retinopathy, there's chance of having like a retinal detachment. So you probably would have had other signs of a diabetic retinopathy before the detachment being caused by diabetes. So that's probably what they were kind of referencing. But I would say the disruption of the cataract surgery was much higher probability of having a retinal detachment than your diabetic retinopathy.
Yeah, that's
Yeah.
kind of what I thought.
Very frustrating with those retinal detachments. Those can happen quickly and it can happen spontaneously. You don't have to have any of those things to also get one. And so, unfortunately, once you've had one in one eye, you're a little more susceptible to getting in the other eye. So, of course, any new symptoms and always the check one eye, check the other eye to make sure.
Well, I've had 3 surgeries on my right eye and still have an oil bubble in. So I know that eventually will be a 4th surgery, but not too happy to hear that I could get it in my left eye, but I will watch for it.
Yep. So just to watch out, you're more likely than someone who hasn't had one. So just to watch out for it. Yeah.
Thank you.
Yeah. Said I can't tell you if you got diabetes in the past 10 years. Okay, so someone was asking about they started seeing an ophthalmologist 30 years ago. For 20 years, he said he can't even tell you're diabetic, which is great. And then the last 10 years, not so much. Twice a year, saying you're bleeding. I guess the question is, what type of bleeding? What's the extent of it? You can have mild diabetic retinopathy and they can say it's bleeding. You can have a hemorrhage in your vitreous. There's lots of different types of bleeding. So it's hard to say without a little bit more detail, I guess. Also having had a cataract surgery, it certainly can disrupt the blood flow of our eyes. And so if we have some susceptible blood vessels, it could have expedited things. But I'd be curious the extent of the bleeding that they're talking about, going from not much to bleeding the last few visits. I don't know if that was from Frank, if they're still in the session or not. Let's see. Or any clarification there. I certainly can talk to you about personally as well. Another question, I have a little bit of cataracts in one eye. Going on 50 and had T1D for 37 years. Cataracts typically get corrected when they become visually significant, which is different for everyone. Typically, surgeons won't do surgery on an unripened cataract, as they call it. So usually when your vision starts to get cloudy and foggy and I would say 2025 or worse for most surgeons, but also the appearance of the lens. If you're having troubles with headlights and things like that, in terms of functionality and symptoms, they'll think about doing it earlier than, sooner than later. Depending on your underlying prescription too, and if you don't have one in the other eye, they take that into consideration just because, if I'm a -6 in both eyes and I have cataract surgery in one eye, and now they can implant some prescription when they do cataract surgery. If I'm walking around now, nothing and -6, that can be very disorientating. And sometimes they'll wait for the other eye to be a little bit more like ready. And so there's a few things to consider there, but usually when it starts to bother you, then they can do different lighting tests too to get it covered by insurance of like your sensitivity to light. So there's more factors they can use now to get coverage with insurance. It's usually medically covered if any of those things are going on. So once you get cataract surgery, you typically don't, need it again. It's very rare. The type of procedure you may need afterwards is called a YAG, where it's a laser that helps to open up the back of your capsule because it can get like a film after surgery, which probably happens in about 30 to 40% of people at some point. That could be year 1, that could be year 15 after having cataract surgery. It can be a little bit more complicated procedure for the surgeon if it's too early and they're not ready for surgery. And then it can also be harder if you wait too long. So there's certainly a sweet spot for cataract surgery. And like I said, considering the type of prescription that you have between the eyes too. So you're not walking around with a super magnified and a super minified eye and getting like double vision and things like that. Some people we call 2020 and some people are 20 happy. So everyone's version of what is acceptable vision is certainly different too. Some people I have to nudge along like now is the time to do it. And other people are asking for surgery. And I'm like, it's barely anything to talk about. So everyone's tolerance is certainly different, but they take a lot of different factors into consideration when getting insurance coverage at least. So that's good.
You see any pilots from time to time that have to meet certain eye standards?
Yeah, we certainly do. And actually, we just got a new visual field that with their requirements of their color vision and their visual field and stuff, we can test now. So we get them from time to time. And I actually just have just finished up a kiddo who is going into air traffic controller school, I think is what he's going for specifically. But he has to follow the same testing that pilots do. And he had a concussion and had disruption to his binocular vision. So he's gone through the whole rehabilitation process and sees, more comfortably, not seeing double vision, not light sensitive. And so he has worked his way back up to he'll now be able to get medical clearance after having a concussion and disruption to his vision. And so he'll be able to now test out of it, which is awesome. But they do have certain requirements of color vision, visual acuity, of course, your field of vision, and we certainly have all that testing on site.
You mentioned that cataract surgery sometimes can cause, I think you said, retinal detachment or bleeding. What are the risks of cataract surgery?
Very small chances, but it can be a disruption into your retina, and so it is a small chance of infection in the eye because they're doing a procedure, retinal detachment. The biggest things that I see in diabetics, though, is not necessarily that. It's more so that we can get a little bit of edema, if anything, in the retina that we need to be on drops for an extended period of time, and once in a while injections after that. But that's the bigger concern with diabetics is just the healing process, and usually needed, for like a typical cataract post-surgery patient, we might be on the drops for 3 to 4 weeks. And for a diabetic, sometimes we'll extend those 6 to 8 weeks.
Okay.
Yeah.
Thank you.
Yeah.
Anything upcoming in Kelsey's life on a different note? Are you doing triathlon, a marathon, traveling?
Well, next weekend I'm getting out to New York City, which I'm excited about, and going to a concert and celebrating my cousin's birthday. So that's the next big thing on the docket for me.
Nice.
Nice to have a little time away. We're certainly very busy, and I just hired another staff on my side of the clinic, and so training them up. But it'll be nice to have a little long weekend away, a little break from it before we dive back in. So
nice. You didn't share the band name. Are we talking about like Spice Girls, Backstreet Boys? You a little bit?
Yeah, Beyonce.
Oh, Beyonce. Okay,
Yeah.
nice.
So yeah, a little performance we'll see, and then yeah, it'll be fun. I went to see her perform when she was in Minneapolis 2 years ago. She puts on a good show, so I'm excited.
I know the Single Ladies Dance. That's a popular one.
Well, now this next album is all country. You're gonna have to add to your dance routine there.
Yeah, it's awesome. Anybody else got other questions? And we've been going a while here. Thank you for presenting. I think it was a very valuable one. It's good to kind of come up because all of a sudden people have some eye things. So it's always good to recap where sometimes it's like, oh, it's not relevant. And you're like, oh, now it is. I'm ready to take care of this. So,
yep. And then there's one last question too, just about the cost of vision therapy. We typically charge about $155 per session. And then you can pay one visit at a time. You can pay in chunks. And certainly we work with you on that on the payment plan. And then sometimes you get reimbursement from your insurance anywhere from $0 to the full amount, depending on your insurance. I've seen like Blue Cross, Blue Shield, Federal get full reimbursement, and then other people got no reimbursement at all. So excellent. Well, thanks everyone for joining tonight. If you have any questions, I'll certainly post my email here too. And feel free to shoot me a message or any questions. Happy to help.